Hola, ¿cómo están? Soy Isaac Hernández, médico en rehabilitación. Estoy en Houston, Texas y soy miembro del Comité de las Américas. Bienvenidos a un episodio más de esta serie Pregúntale al experto. Y hoy tenemos el gran honor y privilegio de estar con el doctor Raymond Onders, a quien conocimos recientemente en la reunión de Asia en Nueva Orleans. Eh, Brevemente comentarles que el doctor Onders es el inventor del marcapasos diafragmático que se utiliza, entre otras cosas, para pacientes con tetraplegia alta que requieren ventilación mecánica. Mencionarles que el doctor Onders es profesor de cirugía mínima invasiva, cirugía general y cirugía gastrointestinal. Tiene una bibliografía extensa que no sería imposible mencionarla toda en este momento, pero cualquiera que tenga interés puede meterse a Google y encontrar todo lo que él ha publicado. Es director de cirugía mínima invasiva en el Centro Médico de Cleveland de University Hospitals. Es director del Centro Comprensivo de Hernias. Es jefe de división de cirugía general y gastrointestinal y es profesor de la Escuela de Medicina Case Western Reserve University. También vale la pena mencionar que el doctor hizo su residencia en cirugía general en los University Hospitals de la ciudad de Cleveland, su internado en cirugía general en el mismo lugar y previamente la Escuela de Medicina en la Northeast Ohio Medical University. Como les mencionaba, se podría hablar y hablar y hablar acerca de todos los logros y publicaciones y avances del doctor Onders, pero al mal paso darle prisa y mejor vámonos directo a la entrevista. Y gracias por haber compartido con nosotros su interés por esta entrevista y compartir preguntas que querían que le hiciéramos al doctor y que así será. Así que vámonos con la entrevista y gracias. Thanks everyone for joining us again. And as promised, I'm joined today by Dr. Ray Onders that I have introduced to you already. Dr. Onders, thank you so much for being with us today.
It's a pleasure to join you and to talk about something I've spent 25 years working on.
That's amazing. And we really so much look forward to it. Where in the world are you joining us from today, since you're always on the road?
I'm in Cleveland, Ohio, presently. So.
All right, just for our audience to know that, I met in person for the first time Dr. Onders just a few months ago at the Asia meeting in New Orleans. And he has had the chance to train a lot of people everywhere in the world. And that brings us to what we want to talk about today. Dr. Onders, can you tell us a little bit more about what is the diaphragmatic pacer and how does it work?
Well, thank you. That's a nice open-ended question. So we do know, as we all do, that spinal cord injury is a catastrophic event. And many people have been working on kind of the worst case scenario of spinal cord injury, which is where you can't breathe. Your injury is so high, you don't control your diaphragm muscle. And so as we know in spinal cord injury or in many other diseases, when you can't control that muscle atrophies very rapidly. And the diaphragm actually atrophies more rapid than any other muscle. You'll lose 50% of your diaphragm muscle mass in just a day of being on the ventilator. In a spinal cord injury, many people will be on the ventilator acutely after their injury, but certain patients, they can't control their diaphragm anymore. So for many years, going back to really the 1960s and even earlier, people looked at, can we stimulate that diaphragm muscle to contract? And so what we do know is that the diaphragm is a very interesting muscle. Once it contracts, it causes that negative pressure in our chest for you to breathe, as opposed to your arm where you have to triceps and biceps for moving. Once your diaphragm contracts, it just re-elongates because of abdominal pressure. So we don't need an opposing muscle to help it work. So there's different ways that we can stimulate that diaphragm muscle to contract. Historically, people had used what we call direct phrenic nerve stimulation. Now, at Case Western Reserve, where I'm at, we do a lot of functional electrical stimulation. Mm-hmm. And over the years, we've looked at, is it safer to kind of indirectly stimulate a nerve by intramuscular stimulation? And that's what, over the 25 years I've been working on this project, for one single muscle, which is a diaphragm, where if we can stimulate the diaphragm near where the nerve comes in, I can get that whole diaphragm to contract. And that's what we look for is, can we help a patient get off the ventilator with diaphragm pacing? So historically, there was the phrenic nerve pacing, and now we actually have intramuscular pacing. The major difference between that is our system can be removable, and we can do this much earlier after the injury. And I'm sure we'll talk about some of the benefits for early diaphragm pacing during this discussion, but this is a system where we actually implant laparoscopically electrodes into your diaphragm so that when we stimulate it, the diaphragm contracts, allows the patient to breathe, and then just by the relaxation of that muscle, they exhale. So the air comes in by the stimulation, and diaphragm relaxes and goes out. Remember, the diaphragm, we all breathe anywhere from 12 to 18 times a minute. So it's giving a contraction of that diaphragm for about a second. Then relaxation allows you to have the air moving in and out of your chest cavity. So that's a basic idea of diaphragm pacing, is to help somebody, fortunately, a small group of patients that have this high injury to breathe without the ventilator.
And is it fair to say that the premise that you just described, that has been the same all along ever since you started? Have there been different versions of the same device that you're using to pace over time?
Well, there was initially the phrenic nerve pacing, which is a good option also, where you directly stimulate the nerve. That requires bilateral chest or neck incisions to place that electrode. And that's also it works well for spinal cord injured patients. The difference with the intramuscular is that we can start much earlier after injury. There's some benefit that we may not injure the nerve. If you have an injured nerve, then it can lead to other problems. With direct muscle stimulation, we can't injure the nerve. But either system works well for spinal cord injured patients. And the intramuscular pacing, we're using it for a lot of other indications in our intensive care units presently, especially during this COVID pandemic, where there's many patients that might be on the ventilator.
No, that makes sense. And that's, I think, a good segue into a different question I had for you. You started out by stating, and we as a group, we're working with spinal cord injury patients, but is there a role for using this pacing device for other non-spinal cord injury patient populations? And if so, what would those be? You just talked about COVID, but even prior to COVID, were you guys using it with anyone else?
Yes, and so there's many other groups of patients that may have this. Many patients, even with a traumatic injury, since we're talking about spinal cord injury, you can have a brachial plexus injury, you can injure your phrenic nerve. We all know that when you have an injured nerve, physical therapy helps that nerve to recover. Distal electrostimulation will help a nerve to recover. Your phrenic nerve can be injured during open heart operations, lung transplants, traumatic injuries to that phrenic nerve. We can actually use diaphragm pacing as physical therapy for the diaphragm. It's the one aspect where you can't put a TENS unit on your diaphragm. You can't actually ask a patient to take a deep breath when they can't move one diaphragm. It's an interesting aspect. If a patient only moves one diaphragm because they've had injured, and you take really deep breaths with that good diaphragm, the other diaphragm elongates and goes up higher because it's being stretched by the negative pressure. So doing too much there, trying a patient to breathe too hard will actually cause more damage to that injured phrenic nerve and diaphragm. So this is just really like aggressive, focused physical therapy for that muscle. And that's what we've learned so much about electrical stimulation. As you know, in many areas, we do electrical stimulation now. For the diaphragm, the only way you can do electrical stimulation is laparoscopically. And again, in our intensive care units, and again, we do know that obviously with the COVID pandemic, we were running out of ventilators and stuff. And we know when somebody has an acute injury that requires a ventilator, like a lung injury from COVID, once their lung recovers, we have to allow their diaphragm to recover also, that physical therapy for the diaphragm. So we've developed programs now where at the time of a lung transplant, the time of a major cardiac surgery, our electrodes we have, we can place and we can just pull them out when we're done. That's what we're looking at even in a spinal cord injured patients. We know that when any patient may just have a thoracic injury, but they're involved in a major trauma that caused that injury. They may have other injuries, kind of injured lungs, bruised lungs, may have had liver trauma, spleen trauma. That patient's on a ventilator in the intensive care unit. So we can actually place these diaphragm pacing electrodes to help them get off the ventilator by maintaining that muscle mass, overcoming this entire what we call ventilator-induced diaphragm dysfunction, disuse atrophy of a muscle that's critical for breathing. And that's kind of the major difference between phrenic pacing, direct phrenic nerve stimulation, and diaphragm. Ours is removable, easily removable. Right. And that way it can be a temporary system because it's a percutaneous system. That's what I look at in many of our spinal cord injured patients now. as we, I always like to say, the most important thing for a spinal cord injured patient is leaving the trauma hospital and going to rehabilitation. The longer you're in a ventilator, the more delayed it is to go for rehabilitation, which really, as we realize now, early rehabilitation helps in functional recovery. If you're on a ventilator, you can't do anything else. You're just trying to get off the ventilator. If we get you off the ventilator earlier, then you have this opportunity for more aggressive therapy that you all do so well with.
No, that's I mean 100% in agreement. You're preaching to the choir, of course, but I think that's exciting what you're describing in terms of its use in other populations and even the early use with our SCI population. So I think that we definitely look forward to what is to come from that. And along those lines, coming back, let's say to the SCI population specifically, who is a good candidate for such a device, whether it's early on or a little bit later on in their course?
What we look at is anybody that's having respiratory problems. Now, that kind of leads to the question is who is not a good candidate? And so that's one aspect. And so what we know in any electrical stimulation, you have to have your lower motor neuron, which is C3, 4, and 5, your phrenic motor neurons, and you have to have a completely intact nerve. Now, we do know, unfortunately, some patients can infarct their spinal cord and lose all of their phrenic motor neurons. Or, as we all know, everywhere in the world is that the United States has the most gunshot wounds to the neck. And so I think it's now our third leading cause of spinal cord injury is gunshot wounds in the United States. It's getting up there. So if I have a gunshot wound to the neck, I'm going to have a blast injury to my phrenic motor neurons. I think I presented at our AGE meeting 2 years ago, is my success rate in gunshot wounds is much less. We used to kind of look at, to make sure that nerve's intact, we used to do the phrenic nerve conduction studies. What we found is that those are difficult to do. They have a high false positive and false negative rate. I published a paper 2 years ago showing that diagnostic laparoscopy. For patients on a ventilator doing a diagnostic laparoscopy, the TV camera through the belly button, and looking at the diaphragm to see if we can stimulate it. If we can't stimulate your diaphragm, then we can't pace the diaphragm. We can't get you off the ventilator. There's something good in knowing that. And that's why I tell some of my patients where unfortunately I go in there and I can't stimulate them. I then tell them, you're still you, but we're going to stop trying to wean. I think we all realize when we try to have somebody wean off the ventilator, and we now know if we can't stimulate the diaphragm, you can't wean off the ventilator. Every day you think you're failing. And it leads to almost a depression. Everybody with spinal cord injury may have that, but if every day you're trying to get off the ventilator and you can't, and I now know you can never get off the ventilator, that's fine. People can live on ventilators for many years. It just changes our focus now. If we stop trying to wean you, we work on all of your other things that we can do for you. Let's sit you up. Let's work on swallowing, other aspects. So it gives me that knowledge early on in these patients and what their long-term prognosis is for getting off the ventilator. It allows some patients that aspect, okay, I'm going to accept the ventilator. I'm going to stop failing every day and weaning because I can't wean. I kind of think that's important. I think that's the biggest contraindication is if we can't stimulate it. Early on, 20 years ago, I'd sometimes say, well, maybe we'll get recovery. Now, if I don't get stimulation at surgery, we don't implant because it's not going to work. And that you don't want to give therapy where you know it's going to fail. That's kind of changed over my 25 years of doing this, is that I can at least honestly tell a patient we're not going to be able to get you off the ventilator, but that's okay. You can be on a ventilator. Your brain's still working. That's an important aspect for your care.
Understood. Plain and simple. Sounds like, it simply allows the patient to be able to start working on moving on onto the next stage, whatever is to come, right? I do know that the providers I've worked with closely here in Houston, they've had the similar approach in that they do this diagnostic procedures in the OR just to avoid those false positives or false negatives. So yeah, and with very good success. So that's excellent. What would you say, if any, would be the most common surgical complications or immediately post-op issues that you've dealt with and as it relates to the procedure and the device itself?
Fortunately, most of these patients are already on a ventilator when taking the surgery, so it's not a high-risk operation. The one thing that we do know that can occur is, because I'm doing this very early after their injury, is that one is you're still in that autonomic dysreflexia area that you can have. You still may have some bradycardia episodes, because I really believe in doing this very early. So that's kind of those common problems you see in the first 10 to 2 weeks after a catastrophic tetraplegic accident. So we do see those things because we're now doing a procedure on somebody, but I feel it's so important to start the process. The sooner we get you off the ventilator, the less likely you'll get a pneumonia, which occurs in 70 to 80% of patients.
Oh, yeah.
We can't prevent pneumonias in these high quads. And so we'll see those things perioperatively when we do it acute. In our chronic patients, we just don't see that. What we do know is that obviously, we know that when I take somebody to surgery, 30% of the time that patient may have infarcted their spinal cord, the nerves were damaged, I can't implant them. So it's not really a complication, but it's that aspect that it won't work for everybody. It's not for everybody, unfortunately, with this type of spinal cord injury, especially if your injury is more in the C3, C4, and it's a very high traumatic or a ballistic with gunshot wounds.
So what would you say is the, on average, what's the lifetime on this pacers? Are they good for life? Do they need to be replaced? Is it just a battery on the outside, or how does that work?
That's a great question. So obviously when we were designing this in the late 1990s, before my first human, we had no idea, but I've now had patients using our device for 20 years, every minute of every day, 365 days a year. Now we do have backups in this. It is, like you mentioned, it's an external device. It requires a battery. So it is, but in the way I look at this is that obviously we all know the problem with electricity, continuous electricity in spots. We know in certain areas in South America and certain areas in Africa, you may not have 24-hour electricity. How do you keep your ventilator going? Or even in the United States, we all know with Hurricane Katrina and all these things, there's vast areas that didn't have electricity for many weeks. So people with ventilators had to go to hospitals. My patients that had diaphragm pacing devices had batteries that last for 30 days. It's just changed the batteries. So you don't need that electricity. So there's that aspect. You can have the external wires can get fractured and we can repair those. But other than that, I was surprised that we don't have that. Unfortunately, as we all know, if you're a high tetraplegic, your survival is not as long. I mean, this is the worst case spinal cord injury. Even in the United States, looking at the Mild Spinal Cord Center databases, even a 20-year-old, their survival, if they're so high you're on a ventilator, maybe only 10 or 15 years because of that. Once you get older, as we all know, a high tetraplegic that's age above 60, as we do know many of our spinal cord injuries are in all areas now as the population gets elderly, there's so many other physiological effects from that is that we don't expect these patients to live forever. If we get them off a ventilator, we actually now have data that spinal cord we now have data that diaphragm pacing decreases your early mortality rate after your injury. So that's actually a very positive aspect for this. And so we also know that, the cost effectiveness of therapy is, the initial hospital stay in US dollars, we save $150,000 the initial hospital stay by getting off the ventilator. The cost for a ventilator per year in the United States is about $150,000. That goes away because you have a one-time device that's just getting the batteries and stuff.
Right, way more affordable for the patient and the system in general. Yeah. Certainly, at least in the US. And so let's say, everything, right candidate, procedure went well, device is working well, short and long term. What about maintenance? What is the patient and or the caregiver to be doing on a regular basis, if anything at all, to make sure that things are, tip top?
Oh, that's a great question. So one of the things we do know, the device actually checks to make sure it works on every breath. So 12 to 15 times a minute, it's actually doing internal electrical check. So it's mostly making sure that you have battery backup. Every patient actually has two devices in case one breaks and the cable to connect it into that area. Other than that, the changing or reprogramming it, one of the things we didn't talk about is we have to program this to give maximal breath, really doesn't change much. Once we figure out the right settings, we don't have to change that much at all. Initially, we have to wean the patient off the ventilator. I think I've implanted patients that have been on ventilators for 25 years. That patient may take 6 months to get off the ventilator, as opposed to somebody I implant at day 5 after their injury that will get off the ventilator in 5 hours, because things are different. But the long-term maintenance has not been a problem for these patients. One of the things I was worried about, because I implant children now as they grow, because the electrodes grow. We know from ventricular peritoneal shunts and aspects that we leave extra slack in there. Right now, I've had a patient I implanted at age 5, and he's now 6'2", and I didn't have to put in new electrodes. So I mean, wow. he's had that area. As we all know, children injured do have the scoliosis problems, and total height doesn't change. But this kid really got tall, and it's still working. That's the one aspect, to make sure you have backup batteries and stuff. And again, because there's 2 electrodes on each diaphragm. So there's internal backups that we designed into the system so that if one electrode breaks, you still have enough other ways to breathe and stuff. So.
Oh, that's outstanding, especially hearing that story about, like you were talking, like a pediatric patient, and now as they grow old and their body gets longer. I think that's a really good segue for one of the, I think a very interesting question for me that we got from when we kind of crowdsourced the group that we work with in Latin America, which is, in general, how are your patients over time doing with the use of the pacer? In my mind, what that question takes me to is, you just talked about one specific patient in the pediatric population as he grew up. Are there any stories that stand out in particular? Because I'm guessing it's in the tens or hundreds of patients that you've somehow been involved, whether directly or indirectly, as you've trained people over time. Is there a story or two that just stand out as to, man, whether it's the first patient that you did, or just something outstanding that just sticks with you?
I mean, I think we all have these great stories of some of our patients that had this adversity. And so I've had many of my patients I implanted in their, before they're in their high school, that then went to college, to law school, and actually and this is something we forget about. If you're on a ventilator, everybody knows you're on a ventilator. Mm-hmm. They hear it. There's the noise of that. You can't go to a movie theater because people will hear it. So you're frightened to go out in public with that. And I get a little aggressive on taking out tracheostomies. I think cough assist, I think what we talk about is that even if you have diaphragm pacing, you're still a quadriplegic, you still don't have a cough. As you know, we're working on cough stimulation systems, but your cough assist to clear your airways, getting that set, working on rescue breathing in case your device fails. I have all my patients kind of do frog breathing, and we know when you're on diaphragm pacing, you use more of your accessory muscles for that. But the ability to kind of go on with your life. I had patients that, got married, had children. I mean, there's all these things that high quadriplegics can still do. And being off the ventilator simplifies a lot of those activities. When you're out in a wheelchair in the community, people are used to that now. They're used to that. When you're out in a wheelchair and you have a tracheostomy, and as Christopher Reeve, Superman, said, that was my tie until we implanted him, is that people look at you differently. Because we've accepted wheelchairs now. But the ventilator changes everything because the noise, the tracheostomy tube. And one of the things we know is once you get rid of your tracheostomy, you have less secretions because you don't have that tube in your neck. So there's less need for constant suctioning. That's probably just that normal life where, people won't notice you as much when you're out and about. And that's what gives excitement to these patients, and to tell them that, yes, I mean, unfortunately, we haven't cured spinal cord injury yet. We can't get you to get up and walk. Getting off the ventilator is that first step for a little bit more normal life.
Right. I mean, wearing my rehab hat, that makes me think right away of quality of life, just kind of a game changer, basically. Mm-hmm. So Dr. Onders, I'm going to switch gears on you a little bit now as we kind of, get towards wrapping this up. A lot of the people that we work with, they have a very strong interest in spinal cord injury. In Latin America, having high tetraplegic patients, even those on mechanical ventilation, let alone a pacer, is not very common. Having said that, just as general knowledge for our group and for anyone in general, what information would you say a provider, whether it's a rehab provider or a primary care provider that does not work directly with such a patient, but let's say they run into one or identify someone that could be a good candidate, what is the information that our providers should be aware of as it relates to the pacer and a patient, and being like, okay, this is what I need to know at a minimum, in addition to getting them with the right specialist?
Yeah. And you're correct. This is truly what we call in the United States an orphan disease. In the United States, which we have 400 million people roughly, right? There's only about 1,200 patients a year in the United States. And this is something in Latin America you may not have as many because, one, they may not survive their initial hospitalization. Long-term ventilator use isn't there. But this is an option that we think works. I think I've mentioned before, we've done implants in Latin America, and Colombia has done a fair amount, and Brazil's done some, Argentina, and other areas we've worked with, and looking at these areas that offer it. The technology is there. Yes, there's an aspect of at least discussing with the patient that there's techniques, that there's something out there that we're still working. Sometimes that's the whole thing, is that there is ways with the electrical stim we can get you off the ventilator. And then obviously, fortunately, the company that builds this is working with many Latin American partners to try to provide this for more people. We do know that it does require surgery, though. It does require somebody to do the surgery. Fortunately, it's a fairly simple operation to do that most general surgeons like I am can do this, are trained for it if they do something as simple as a laparoscopic gallbladder operation. It's that technically that hard, or it can be done. But it is hard for technology to go throughout the world where we need it everywhere, as you're well aware of it, working with this for so long.
Yeah, of course. And just exclusively anecdotally, but in talking to a lot of colleagues in Latin America, you're absolutely right in that a lot of the high tetraplegic injury patients, they just don't make it, maybe not even to the hospital. They may even, pass away out on the field. But part of what we're trying to do as a group over time is to try to provide some data to this that can back up those anecdotes. And as we hopefully very slowly but surely grow our knowledge of things and how to best help out. And as you said very well, because you know it firsthand, there are some individuals out there that have benefited from your technology, that hopefully those numbers over time can grow, and that we can be some kind of a bridge, at least in terms of the information, availability. And speaking of which, and I think this is my last question that I have for you, people want to know more about this. What is a good resource? Is there a good website? Is there a specific paper that you recommend? I know there's tons of papers, including coming from you, but is there like your golden paper, or like, pacing 101? What is your suggestion for those that want to get just a little bit more information?
That's a great question. Again, fortunately, there's certain things that have come out that the American College of Surgeons in the United States now recommend this as a guideline for trauma centers, which at least helps the United States, but most countries then follow our trauma guidelines for that, our level 1 trauma system. So you'll see this more commonly. Obviously, if you just Google my name, you'll see all my articles and stuff, Onders. The company's website is Synapse Biomedical. They actually have things in Spanish available on that. So that would allow, we actually have our instruction manual is in multiple languages, including Spanish. And that'd probably be the easiest way to look at that through that website. And so otherwise, it is something where we don't. This is a great idea here. Just sharing the knowledge through this podcast, it will help quite a bit to get that knowledge out there. And again, it's one of the things I like to say. Fortunately, this is a rare disease. Unfortunately, rare disease, it's hard to actually get it everywhere for this rare disease. What I think in the long term is really going to change is our use of temporary wires and other diseases. The most common is open heart surgery now. And so every country in Latin America does open heart surgery. It's around there. We now have very good data that are temporary wires and high-risk open heart surgery. That would allow the technology to become more common in the area, where people then could utilize it for spinal cord injury patients that probably need it quite a bit. So that's some way that I think in my heart, that's how we're going to help patients around the world with this, is having this technology available for other indications will allow it to enter many other areas of the world that need this type of technology. That, as we all know, is that most quadriplegics' brains are completely intact. It's just their body and their muscles not working. And if we can at least give them that little bit more freedom from the ventilator, that's going to allow them to get a little bit more normal life, to proceed on with their rehabilitation.
Well, especially early on, as you mentioned, right? Or the sooner the better. I think that's exciting. The way you make me think of it is using this cardiac surgery as a vessel to expand into other areas. And it also makes me think of, more surgeons that become familiar with doing this, well, then that means more people everywhere that actually can provide it. And one way I think that we like to think of our group as is also as a vessel, or as a middle person to be able to share and translate information for others. So needless to say, we're more than happy to be able to share this with everybody that in Latin America that follows us. Fortunately, this has grown over time. So we'll make sure to distribute it. We'll make sure to have it subtitled and available in Spanish. And it's very exciting. This is a topic that easily you and I and some of our colleagues, like Dr. Longoni, when we met back in New Orleans, I forget how long we spoke. It was 2 different times on the same day, but we definitely could keep going and going. So in the interest of your time and appreciating the time, as I know you just finished clinic and I know how busy things are, on behalf of the Asia's Americas community, I really want to thank you for taking the time to meet with us. More to come, I am sure. And I think not for you, but more for our listeners. Correct me if I'm wrong, but I know that when and if, you know, something were to come up, I encourage whomever is listening to reach out to our committee, and then we're happy to facilitate any information. Or I know that you know who you have trained anywhere in the world that we can get in touch with, depending on what country we're talking about, to see if something can be done about helping, you know, the patient or the loved one or whomever it may be that we're you know, talking about. So thank you so much, Dr. Onders. I don't know if you have any final words you'd like to share with us,
I
but
really appreciate you having me here. It's been a pleasure to talk with you. I appreciate everything you do. We're all trying to help as many patients as you can. The Asia Americas Committee is doing a great job to help, and I'm available at any time. I'm sure they all have my email, my cell phone, and I may not respond in a day, but I always respond to my email.
No, I'll on your behalf, definitely excellent communicator. I appreciate all the openness and willingness to be there and help out. It's priceless. So thank you so much. And until next time, I look forward to it.
Okay, thank you.